So it's the year of the dragon, and anyone bought Toto yesterday? And if you haven't had time to check, I've just listed the winning numbers at the bottom on the right. So if your neighbors start shouting later on when all the 6 numbers are out, it's not because it's manic. So as Dr. Mok has told us, about 1 to 2% of people over their lifetime will have bipolar disorder in Singapore. And as we know more and more, bipolar disorder is actually a chronic relapsing illness, and they will need maintenance medication throughout their lifetime. And it's not something that's just episodic and will go away. In fact, 10 to 19% of individuals actually would attempt suicide, and some of them will complete suicide. So this actually has significant costs in terms of lost productivity, in terms of family having to pay for medications, in terms of having to care for the patients. And this is the reason why we have decided to choose bipolar disorder as one of our clinical practice guidelines for mental health. For those of us who are in psychiatry, we would know that one of our pioneers psychiatrists who described bipolar disorder would be Kraepelin. And initially he did describe bipolar disorder and schizophrenia as 2 very distinct disorders without this overlap or of any sort. But more and more with research and from our clinical experience, we know that actually bipolar disorder and schizophrenia are not 2 distinct disorders. They lie on a spectrum, and it's a dimensional approach rather than a categorical approach. And as we all know, we already have guidelines for schizophrenia and CDMP, chronic disease management program for schizophrenia. So sometimes what happens is that because of the instability of the diagnosis or instability of the diagnosis, when your patients are first diagnosed with schizophrenia, they qualify for CDMP, and suddenly they have a manic episode, the diagnosis may be changed, and what do we do with them? Do we say that, hey, now suddenly you don't qualify for MediSave anymore? And therein lies another dilemma. We also have for mental health the CDMP for depression. And lo and behold, a person with depression for the first episode comes to you, apply for MediSave, but maybe the second episode he has a manic relapse, and then we describe it as a bipolar disorder or diagnose it as a bipolar disorder, and he loses his MediSave. So administratively, it doesn't make sense this way. And therefore, adding bipolar disorder as a CPG for the platform to launch it as CDMP is very relevant and would help to encompass all these 3 disorders in their many dimensional form together. And we all know for now that the bipolar disorder will be the 3rd mental illness for chronic disease management program later on. Okay, so for the boring parts of things, bipolar disorder is diagnosed with 2 standard diagnostic category. One would be the ICD-10, International Classification of Disease 10, and the Diagnostic Statistical Manual for text revision. For bipolar 1 disorder, it is described as 1 or more manic episodes or mixed episodes. And individuals often have 1 or more major depressive episodes, but not necessarily so. Bipolar 2 disorder is described as 1 or more major depressive episodes accompanied by at least 1 hypomanic episode. So these are the definitions. And for mania per se, the symptoms are as such: elevated, expansive, or irritable mood lasting for at least 1 week, with 3 or more of the following: inflated self-esteem or grandiosity. This can be of a psychotic nature. They can have a grandiose delusion. Decreased need for sleep, more talkative than usual. Okay, flights of ideas, distractibility, increase in goal-oriented directed activity or psychomotor agitation, and excessive involvement in pleasurable activities that may have a high potential for painful consequences. Could be that they can be involved in, they can become hyposexual and start having more sexual partners when they usually would not be doing so. So, well, who can remember so many things, right? So usually we use a mnemonic, dig fast, and if you could just read dig fast quickly just to go through, it's the same thing. D for distractibility, I for indiscretion, G for grandiosity, F for flight of ideas, A for activity increased towards goals, and S for sleep deficit, T for talkativeness. Okay, for hypomania, basically it's the same set of symptoms, but then it needs to only last for 4 days, and usually in hypomania, the episode is not severe enough to cause marked impairment in social occupational functioning, and they would not need any hospitalization. Also, there would not be any psychotic symptoms. For depression, it's 5 symptoms for 2 weeks, or for a 2 weeks period. There are 9 symptoms that we need to remember here. Depressed mood, diminished interest or pleasure, significant weight loss or weight gain, insomnia or hypersomnia. So it can have poor sleep or increased sleep, psychomotor agitation or retardation, a feeling of loss of energy, they may feel worthless or have excessive or inappropriate guilt, decrease in concentration, and also suicidal ideation or suicidal attempts. And again, to ease us in remembering the diagnostic criteria, you can remember in set cages. In for interest, the loss of. Sleep for sleep disturbances, either more sleep or less sleep. Appetite, A for appetite and weight disturbances can be an increase or decrease of weight or appetite. D for dysphoric or depressed mood. C for concentration poor. A for activity, either increase or decrease. G for guilt. E for energy decreased. And S for suicidal ideations. Alright, so there is also this entity called the MAIDS episode, which can be quite confusing sometimes, but basically the patient may, for that day, qualify for both the criteria for a manic episode as well as for a major depressive episode. And it must last for at least 1 week. Psychotic symptoms can be present in the more severe episodes of mania and depression, and this can come in the form of hallucinations, them hearing things, and it can come in the form of delusions. Most frequently, you'll see people with grandiose delusions thinking they have special power or they are someone special. Okay, and there is this entity called the rapid cycling, which are a lot more difficult to treat. 4 or more episodes of a mood disturbance in the previous 12 months. We did some research on, and literature search on early diagnosis and intervention. From our experience and from the study that's present in the literature, it does seem that the prodromal stage of bipolar disorder is not so well established, and therefore we decided not to include any form of treatment guidelines within the CPG-4 prodromal stages. However, when the patient has been diagnosed, early diagnosis of the first episode of bipolar disorder itself and timely intervention will improve long-term outcomes. And when you treat them early and you treat them well, they are less likely to experience personal, social, and work-related problems. One of these very obvious problems that they may have oftentimes is that when they are hypomanic or they are manic, the spouse may actually misunderstand the symptoms and think that, hey, why is my husband becoming so irritable, so difficult? And some of these social problems that they have include divorce. So treating them early, getting the family in early, explaining things to them will help a lot in that sense. Well, differentiating major depressive disorder and bipolar disorder is actually quite difficult. So oftentimes we have patients who come to us presenting with depression. And really at that first presentation, there's no way you know whether this is bipolar or not bipolar. However, when patients will present with depression, it is necessary for us to have a thorough assessment for any previous history of hypomania behavior or manic behavior. Because of temporal instability of bipolar diagnosis, we do know that accurately diagnosing bipolar disorder may take many years. In that sense, it is a retrospective kind of diagnosis, because you do need to have a temporal timeline to see the number of episodes they have and then make a judgment of whether this is bipolar or not. Okay, so that's the end of my presentation. Anyone strike Toto? Apparently not. Okay, thank you.